Bienvenidos todos a esta sesión de la tarde. Welcome all to this late afternoon session where we are going to be dealing, thanks to some very high qualified speakers, with the substrate underlying atrial fibrillation. We thought a lot about channels, conduction, refractoriness, and electrical remodeling, but more and more it seems that there is some kind of tachycardia or myopathy in the atrium, and that should be taken in very generic terms. We have an interesting technological situation. Dr. Andreas Goette has been unable to take the plane in the last minute out of some not important, fortunately, incident, but he could not leave for Madrid, and he's going to give his talk by Skype, so we'll have him here. Apparently, Dr. Marrouche is getting here in a few minutes, not sitting here with us now, but he's in Madrid and he'll be sharing with us. And without further delay, I would like to introduce Dr. Andreas Goette. If we can have the connection now, please. And Andreas, here we are all. Welcome, even if it couldn't be, but through the internet, we can see you well, and hope we can hear you well also.
Dear Paco, thanks a lot for the very kind introduction. I'm very sorry that I cannot be in Madrid. However, your colleague, and this really is the excuse, broke his wrist 2 days ago. So this is definitely the picture we're facing right now. He was supposed to cover me, but he's unable to do catheterizations. For that reason, I had to do the catheter ablations today. So that's the reason why I wasn't able to join you for your wonderful meeting in Madrid. So these are my disclosures. Honestly, I'm very honored to talk about atrial cardiomyopathies because probably not very many people in the world really know a term atrial cardiomyopathy. However, everybody really knows ventricular cardiomyopathies because, of course, we have learned over the last decade or so that, of course, there's a variation of different ventricular cardiomyopathies, and we do know that actually the outcome and benefit of different therapies is really different in this different setting. However, the question really is, what is an atrial cardiomyopathy? So there are many hints in the literature, of course, that atrial myocytes react similar to ventricular myocytes to different stimuli, like angiotensin, growth stimuli. We have sarcomeric disorganization, we induce hypertrophy, or also apoptosis. And we do know, of course, that atrial fibrillation can actually contribute quite substantially to these alterations. And we always talk about substrate, we always talk about different aspects of atrial fibrillation. However, I think that it's very important to talk about the different pathological alterations in the tissue during atrial fibrillation. So for that reason, I think we need to have a term which actually combines all concomitant diseases and the aspect of different concomitant diseases on the interstitial matrix, as well as on cardiomyocytes and fibroblasts, because all these phenomena interfere with the contractile performance of atrial tissue. They interfere with conduction abnormalities or also with impulse generation. So I think to have something as a common background is very important, because otherwise we just talk about fibrosis or structural alterations or structural abnormalities if we deal with diseased atrial tissue. And for that reason, of course, it's important really to realize that we do have now the knowledge coming from the last 15 decades or so that in the cell there are tremendous alterations due to oxidative stress, due to overload of calcium, that we have disintegration of contractile filaments, we do have swelling of mitochondria, we do have the activation of different phosphatases as well as proteases, and for that reason these alterations need to be acknowledged in a disease process. Besides just cellular changes, we also have substantial interstitial alterations like, of course, fibrosis, which is predominantly seen in patients with atrial fibrillation. However, we do know that many patients, especially with mitral valve disease, for example, have substantial amount of fibrotic tissue. However, they do not fibrillate. However, the pathology is still there, and for that reason, we cannot just discriminate patients with and without atrial fibrillation. We really need to focus on the pathology itself. And furthermore, of course, we do know that so the interaction of collagen with tissues, myocytes can be altered, and disruption of this interaction really leads to dilation of the tissue. So we do know now substantially how atrial and how tissue is actually changed. So in addition to these structural changes, we do of course know that we have metabolic alterations like changes coming and induced by diabetes. So especially diabetes does not induce interstitial alterations. However, it really induces also changes at the endocardium. It may induce both thrombogenic alterations and also set up a scenario where these tissue actually can be much easier. So the question now is how actually different aspects interfere with the tissue, and is fibrosis really the final common pathway? And we think that this actually is not the case, because we know that there are features of amyloidosis, and we know that amyloidosis is really induced by misfolding of various proteins which are secreted and synthesized, especially in the atrium. And of course, there is a protein very prominent in the atrium, and that is atrial natriuretic peptide. So the question is atrial natriuretic peptide really also present in the atria when you do have amyloidosis? And indeed, we did a large group of analyses, including more than 200 patients. And indeed, we can see, especially in elderly women with mitral valve disease, a substantial amount of amyloid. And usually, the amount of amyloidosis is inversely related to fibrosis. So there are indeed different pathologies in the interstitial matrix. And we do know, of course, that amyloid induces substantial different alterations in comparison to fibrosis. So just by doing mapping technologies like voltage maps, you cannot discriminate between fibrosis and amyloidosis. However, the aspect of pathology is substantial. And for that reason, we know, for example, that there is a gender-dependent arrhythmogenic substrate in the atria, because atrial stretch and estradiol induces ANP, and then we have misfolding of ANP protein that interferes with conduction and allows atrial fibrillation to occur. And of course, we know that if atrial fibrillation develops, ANP secretion is increased. So we have a positive gender-dependent feedback loop, which may actually cause, especially in elderly women, the development of isolated atrial amyloidosis. So no other organ is involved, it just interferes with atrial tissue. So having all these aspects in mind, actually, the European Heart Rhythm Association, thought that it's really time to define atrial cardiomyopathies. And we had actually a chance to work with HRS, APHRS, and Soleace together to define for the very first time a global consensus report on the definition of atrial cardiomyopathies, because we think that even in patients without atrial fibrillation, it might be of interest and very necessary to have a common global-wide accepted definition for an atrial cardiomyopathy, and also a different classification that we actually can use different terms, and that we can use these definitions also with the tissue. So several different people from Europe, from the US, from the Asian region, as well as South America, work together. And these are the names listed here who actually contributed quite substantially to So we came up with general definition of atrial cardiomyopathy, and this is called of structural, architectural, contractile, or physiological changes in the atria with the potential to induce clinically relevant manifestations. So this, of course, is a very broad definition. However, we think that this can actually help to define all different aspects. We discussed the issue if we need secondary and primary cardiomyopathies. However, there's a substantial overlap also with ventricular cardiomyopathies, and it's always hard to define if it's primarily related to the atrial tissue or if it's secondarily related to other diseases. So for that reason, this broad definition may actually help to discriminate which actually is present in the atria itself. However, we came also up with a classification, and this classification is called ERAS, including all the different associations who contributed. And we thought that an ERAS classification of 4 groups, which are not stage dependent, so there is no progression from class 1 to class 3 or class 4. However, it's just a discrimination and description of the different pathologies. So ERAS class 1 means changes just referring to the cardiomyocytes. If we do have changes predominantly interfering with interstitial collagen accumulation, for example, aging is such a process, it's called ERAS class 2. If we have a mixed type where we do see changes within myocytes as well as in the interstitial matrix, it's ERAS 3. It's typically seen in patients with congestive heart failure, for example. Or we do have a class 4, and this actually refers to atrial amyloidosis. We have inflammatory infiltrates as also other infiltrations like fatty infiltrates. So this is a different description of the different ERAS classes, and we think that this is a very interesting type to actually describe what's going on in the tissue if we really have a chance to look at the different pathology under the microscope, for example. So what actually does it mean if we look under the microscope and to see different changes? So what does ERAS class 1 look like? And this is normal tissue from atrial, coming from atria from patients with no heart disease. And this is someone who has pathological alteration of the myocytes. You can see that the nuclei are probably a little not so dense. And even in larger magnification, you can see that there's an accumulation of glycogen around the nuclei, that there's a disorganization of the contractile apparatus. So this is truly just seen within myocytes. There's no accumulation of collagen or whatever in the interstitial matrix. So this is a typical picture of myocytolysis we see in ERAS class 1. And this is a more dramatic picture, actually, where you can easily see that there's a lot of disorganization and disruption in the myocytes, and heavily swelling also of the mitochondria and glycogen accumulation. So this is the ERAS class 1 picture. ERAS class 2, it's easy, it's just normal myocytes with substantial collagen. So this is actually often the case that we do see collagen accumulation, which is more than age dependent and normally there. However, we also know that the orientation of collagen and not only the overall amount of collagen really interferes with conduction slowing and the occurrence of arrhythmias, for example. So ERAS class 3 is a mixed type where we do see heavily altered myocytes as well as interstitial alterations like seen on this slide, where you see collagen accumulation substantially here also as well, and alterations of the myocytes. And this is the typical picture you can see in patients with congestive heart failure, also with mitral regurgitation, for example, where you do have massive alterations of the structure. However, I think very importantly, and probably not very realized and in the last years actually, is ERAS class 4. I've already alluded to isolated atrial amyloidosis, which is seen here. However, we also see fatty infiltrates. So we do know that there is massive fatty infiltration with normal myocytes in many patients, which may also depend on the body mass index. However, these interference with the fatty cells actually has substantial impact. And interestingly, we also know that the fatty tissue is also active on the neurohormone level. So they actually secrete different proteins and proteases, and this is shown here because if you look at the pericardial fluid, you can see that there are, of course, differences between men and women with regard to the neurohormone activity in the pericardial fluid, and many of these aspects actually do come from fatty cells. And you can see, for example, that the ratio of the angiotensin converting enzyme to D-peptidyl peptidase 4 is actually massively altered in women but not in men. So actually there are many aspects which need to be clarified to understand all the different pathologies. And finally, of course, there is myocarditis going on also in the atria, and here you can see massive inflammatory cells between the myocytes. So this is a classical picture we would call ERS class 4I for inflammatory aspect. So I think that these alterations are of importance, and one aspect is actually the occurrence of stroke, because of course we know that patients with atrial fibrillation have a risk, if they do have a chest vest risk factor score above 2, that they may suffer a stroke. However, if you actually look during the time when strokes occur, here on this line, that many of the patients did not have atrial fibrillation for more than 365 days, or at least 180 days, with no episode of atrial fibrillation. So, and many of the patients actually had only episodes after they suffered a stroke. So the question really is, why do they actually develop atrial clots if atrial fibrillation is not always there? And if you think about the Weichel's trials, you can see that slow blood flow is one aspect, however, that you need to have endocardial alterations. And interestingly, and this is also an important aspect of the topic of atrial cardiomyopathy, that all these parameters listed in the CHEST-VASc parameter scoring system, like hypertension, aging, diabetes, congestive heart failure, they scale with the atrial tissue. They induce oxidases, they induce oxidative stress regulation of proteases and phosphatases, and all these factors drive the endothelium to be more thrombogenic. So in these aspects, and that is of interest, occur predominantly in the left atrium, but not in the right atrium. So patients with atrial fibrillation do not suffer from recurrent pulmonary emboli, they suffer from stroke and systemic embolism. And this also explains why the CHEST-VASc risk parameter are present even though the patient has not to be in atrial fibrillation all the time, because a diabetic remains a diabetic, a hypertensive patient remains a hypertensive patient, so the endocardium really remains very prothrombogenic in these patients, even though they may have longer periods of sinus rhythm in between. And that explains why actually the likelihood to suffer a stroke does not directly relate to the presence of atrial fibrillation on the ECG. So this is actually also a concept that explains atrial thrombogeneity of the left atrial endocardium, and the process is called thrombogenic endocardial remodeling. Because I think it helps, and to understand why just the duration of atrial fibrillation or so is not a very good predictor for atrial thrombogenesis, but the CHEST-VASc parameters are. So, of course, there are many other factors, and they are listed also in the consensus paper, which may contribute. I do not want to go over this. However, I think that this concept of atrial cardiomyopathies might be very helpful, really, to describe different pathologies in different patient cohorts, and I think it may provide a basis, actually, for also electrophysiologists, of course, how they should ablate, how they should deal with different cardiomyopathies. Although at this point it might be very hard to discriminate the pathological forms one from the other. However, I think it's important to understand that fibrosis is not always the case if we talk about structural alterations. We do not know how amyloidosis will respond to recurrence, for example. So definitely we need to do further research on this, because I think it's very important to understand why in some cohorts, probably catheter ablation may work very well, and others probably less, and also why we do have different occurrences of stroke in different subcohorts of patients with atrial fibrillation, or at least with damaged atrial. And I think the concept of cardiomyopathies, I think it's the first step. I'm pretty sure that we can probably do better and come up with other and further more elaborated type of definitions, classifications. However, we are very happy that we could actually produce this document and publish it last year in all the 3 major journals from all the different associations. And I hope that you could hear me well, and I'm very happy to take your questions. And again, I'm extremely sorry that I could not fly to your very nice city in Spain, Madrid. Thank you.
And please, Nassir Marrouche, thank you for fighting the Madrid traffic, and here we are. And Dr. Marrouche is going to speak about magnetic resonance imaging of atrial fibrosis, feasibility, limitations, and relevance to AF ablation strategies and results.
Professor Cosío, Professor Ramos, thank you so much for inviting me to not only the great meeting, but a great city. Always a pleasure, great pleasure to be in Madrid. I'm trying to fix the microphone. The topic was given to me is magnet resonance imaging of atrial fibrosis, feasibility, limitations, and relevance of AFib for AFib ablations. So I want to share with you the journey. Before I start, this is my disclosures briefly. Put them up here. I want to start talking to you about this is the outline of my lecture today. I want to start talking about imaging atrial fibrotic changes and scar and how we achieve this. And this is very important for the audience to know and to go through the process. And it's been now 10 years since we started this program at the University of Utah. Actually, one of the major champions of this program who was with us, Felipe Basbal is here, was from Barcelona. Detecting fibrotic progression. This is a new finding which is very important for everybody in managing EP and AFib specifically. And last 2 topics were looking at fibrosis and the clinical implication, how we're using it in clinic today to guide our treatment of our patients. And last but not least, fibrosis as a treatment target, which is you heard a lot about from Dr. Arns from Freiburg. So starting with using MRI to detect atrial fibrotic changes or substrate, and it's very important for everybody to know it's really a combination of 2 things. The MRI sequence that you use plus the image processing. So you have to put this together into one concept, and we learned a lot over the last 10 years. If you look at the first image we used and we achieved, which was for us a major success in 2007, obviously you can really delineate and detect the atrial wall very clearly. And we went far with Dr. Kolmovsky and his group at the University of Utah, the Karma Center, tried to refining this image day by day. But this is how far we were in 2007. And if you look at the image processing part of this, which is shortly after 2008, you can tell we used to look at fibrosis in shadows, just black and gray and so on, and this is the ablation scars. So from there, we went very far to get to here. And this is today's sequence of atrial fibrosis. We call and by the way, I'm happy to announce that this fibrotic sequences are called the atrial fibrosis Utah sequences are available at the GE and Siemens magnet since November 1st. So anybody in the world, you can call Siemens if you have an MRI scan and tell them I want the atrial fibrosis Utah sequence, and you can get this, or a GE sequence. We're working with Philips closely, but clearly you can see very nicely the atrial wall, and this was the work of a couple of years to get there. Now we are there with 2017. And image processing wise, I mean, what we do, we take the MRI sequence and we process them based on thresholding the atrial wall, and we detect healthy tissue, the blue versus green, and different grades of green. And this has been used recently and in DCAF2 as well. But it's very important for you to know, and this is one of the most important papers that we publish at the Karma Centers in the last 10 years. And sorry, it's cut off here. I don't know why the slide, but it should show McGann's paper where he did the biopsies on open heart surgery patients who have a mitral valve or CABG replacement treatment, and he could correlate these findings to histology. And it's very important to know that this kind of slowing of gadolinium could reveal this green or deep green color versus this as well. So these two patients have AFib, different grades of fibrosis, and I will show examples later. But keep in mind, whenever you look at green or whitish, you need to keep these images in mind, that this is the amount of fibrosis we're dealing with. And these are a collection of fibrosis or AFib patients we see in our clinics. This is, in fact, these are 64 patients from the DCAF1 study from worldwide centers. And you can tell you have little fibrosis, almost no fibrosis versus extensive fibrosis. And the reason why MRI helps us to detect this kind of fibrosis, and this is very important. You heard a great lecture from Dr. Goette about the atrial myopathies. But the human AFib patient we see, they all have patches of fibrotic changes, at least the one we image with MRIs. You almost none, you see zero fibrosis, no changes. And in fact, if you image patients older than 60 years old, this is a study, we already have 160 patients in Utah, have no history of AFib, you find 60% of patients have atrial myopathy, between 5 to 30%. So the myopathy is already happening, and this is a big article we wrote in European Heart Journal describing it, that really the myopathy is the problem rather than the AFib as a consequence of these changes, and hopefully we can already early detect the change before they happen. One of the things that I want to talk about, only a couple of slides, but this is a very important finding for us in Utah and hopefully for everywhere else who's imaging atrial fibrosis, is the detecting progression of fibrotic changes independent from the AFib burden. And now we're scanning patients without ablation or with ablation multiple times over years at follow-ups. And this is an example of a patient with persistent AFib, an MRI, and a year later MRI. You can see there's rarely any changes in progression, no changes. Although the AFib burden was persistent, changed more, we're trying to treat this patient. This patient can still be ablated, for example. Versus this patient here, have a really significant progression of atrial fibrosis, a posterior wall veer, within 1 year, although paroxysmal AFib, yes, some increase in the burden. But keep in mind that fibrosis has its own rules and progression. It's a progressive disease in some patients. But if you look at this paper from Labidi from our lab, Muhammad presented this at American Heart, and he practically, what he shows here, that around 30% of the patients have between more than 5 to 10% progression at 1 year, but not everybody progressed in 1 year. Now we have a 3 years follow-up study, and hopefully we can report more. So fibrosis does progress, moves on, independent from the AFib behavior. And obviously we're looking deeper and deeper to understand if drugs are involved suppressing it, there's something that stopping it. With this number of patients we have, the study is not done yet, but this is a 160 patient progressive study. This is another study that Alan Morris presented recently with Pim Gal, who joined with us from Holland for a 1-year fellowship. He looked at the progression of new areas of fibrosis after ablation. So when you see red colors like this in image processing, you're looking at ablative tissue. And this is a patient of ablation, and 3 months later or 6 months later, this is another patient. They have huge new area of enhancement of changes after ablation. And this is another patient, complete recovery in new areas of superficial changes and new areas of fibrosis. And the reason I'm showing you this seems to be plays in a very important role for failure of AFib ablation procedure. And everybody in this room who ablates AFib and have a recurrence after 3 months will say, oh, we always blame ourselves for bad ablation lesions, bad targets. But the only thing we never think about that, you know, our ablation lesions could be great, but the disease is progressing, initiating new areas, new triggers. So when you test the technology, is it balloon versus RF? Is it lines versus no lines? We always look at the recurrence 3 months and say, okay, we failed. But we need to factor this into our success story of failure, because this is a factor. Today, there's no way we can manage it. It's progressive disease in that atrium. Again, you heard the whole lecture about it. So keep this in mind when the patient recurs after AFib ablation or cardioversion or drug or whatever. It's not only your ablation lesions that's failing. There's other factors you need to factor into your equation, like the progression of fibrosis, which I think is very important neglected factor in treatment of AFib. Fibrosis predicting clinical outcome. We learned a lot over the last 10 years, collecting these images and looking what happened to the patient. And this is a very important slide. This is a slide from Nate Segerson, who used to work with us in our lab. He moved to Seattle. But he looked at our patient with fibrosis. This is a series of 780 patients and correlated them with the type of AFib. He looked at paroxysmal AFib, permanent or paroxysmal or persistent AFib. And Utah 1 means that less than 10% fibrosis, 10 to 20% is Utah 2, and so on and so on. What I want to give you here to take home with you is, if you look at this one here, with little fibrotic changes, you still have almost 50% of the patient persistent or permanent. And again, this is in progressive fibrotic changes here, although the majority of patients have persistent, but a significant amount of patients still have paroxysmal AFib. So the AFib behavior doesn't really exactly follow strictly especially in early stage of disease, persistency or paroxysmal AFib, the AFib phenotype. Keep this in mind. You will have a patient, and the reason I'm telling you all this, because we see a patient with paroxysmal AFib coming to our lab, we also think of, let's look trigger and only trigger, and we end up with 55% success rate. Any multi-center study done worldwide today have the same success rate, paroxysmal persistent, 55%, 60%, 55%, 60%. Until we look at single center study, we have a great success rate, but if you have the multi-center success rate, over depressive, because I think we put paroxysmal and persistent in the same box. So, different boxes, sorry. The DCAF study told us a lot. DCAF 1, there's DCAF 2 ongoing now, but DCAF 1, what we did, we looked at MRIs in 15 labs worldwide. We asked everybody to ablate their patients. There was, Felipe and Monta from Barcelona was part of the study. So we blinded the people or the operator to these images. So you will ablate AFib, but you did not know what the image looked like. And we looked at that follow-up 3 months after, and we looked at MRI 3 months after, look at lesion formation. So what we found in DCAF 1 is that the more fibrosis you have, the higher chance of recurrence. And the early stage of disease, they do better, independent if the patient has paroxysmal or persistent AFib. And this is, again, any kind of ablation procedure we'd use. And this is our data from Pim Gal, who presented at American Heart as well, trying to publish, looked at our data from Utah, our 6 years follow-up. And you can tell stage 4 have only 5% chance, if you do nothing with them, staying in sinus, while stage 1 and 2 remain significantly associated with a good success rate. So again, keep this in mind. It seems that these patients progress more and more. This is a work from Hopkins, where they published similar data looking at outcome based on MRIs and fibrosis detected with MRI and outcome. And they say the more fibrosis, the less the chance of suppressing AFib per ablation procedure. And this is again in persistent and paroxysmal AFib patient combined. And then we learned a lot in terms of stroke risk beyond the ablation procedure. Patients who have more than 20% fibrosis, Utah 3 and Utah 4, have multiple-fold increase of risk of stroke when we see them and when we follow them. Dr. Akoum from our lab looked at the incidence of thrombus formation and spontaneous echo contrast and left atrial fibrosis, and he saw a very powerful ROC, or the area below the curve, C statistic of 0.83 and 0.82. That's way more powerful than the CHAD score. CHAD-VAS score we use today of 0.67, predicting strokes or clot formation at least. And you heard in the first lecture today from Dr. Goette that it's the thrombogenicity of this atrium that plays a role, not the AFib itself. And that's what the data has been showing, independent if you have AFib or not. That's what we're seeing. Dr. Akaya from Turkey, who was in our lab for 2 years, he looked at the correlation with LV dysfunction and fibrosis, and he tried to look at generalized cardiomyopathy versus localized cardiomyopathy, and can show a very nice correlation. The weaker the ventricle, the more fibrosis you have. Dr. Jordan King, who was with us now in California, looked at MACE, major adverse cardiovascular events, including MIs, mortality, hospitalization, and stroke. He put them all together, a series of 1,200 patients, and he found this very strict correlation over time and between fibrosis and the risk of MACE. Patients die more, stroke more, and then get more MIs and hospitalization, especially when you start cutting the 20% cut off on the left atrial image. And the beauty about this is not the mapping procedure. This is a very objective MRI scan and test. We cannot neglect the ventricle when you treat AFib. We always do, but now we can't. And MRI is opening our eyes on this. This is a new image processing model that we're putting in the DCAF2 study. We're looking at the ventricles as well. If you look at this image, you see these two lesions we put together. You see them very nicely here. But what we integrated here is something called T1 mapping for the ones who doesn't know MRI and LG imaging into one equation for image processing purposes. And we can detail the red areas, the areas outside the scar, and how they behave over time, and look at incidental finding. And what we're finding over time that this area, if you 11% of your AFib patients who come to your lab have lesions in the ventricle that are not associated with coronary artery disease or other cardiomyopathy, just lesions. And if you take this into consideration, these patients, this is important when you find this, because these patients, this is one of the patients where we call them like significant disease in ventricle. This is nothing. And the reason why this is important, this is a paper from Brent Wilson in JACC, where he showed that this is very important for MACE because it predicts this finding in the ventricle in an AFib population, higher incidence mortality of cardiovascular mortality, MI, and ischemic stroke. So keep this in mind. The ventricle is part of the AFib treatment, not neglected. If you have an MRI scan, ask your imager what the ventricle is doing. Last but not least, fibrosis as a treatment target. You heard a whole lecture from Dr. Arntz about this. And this is, I want to congratulate this group of their work on low voltage and fibrosis imaging and ablation. But this is what we learned from DCAF2, from DCAF1, sorry, not DCAF2, that we took the images. So we looked at as spies, as on all the operators, and we looked at how did they ablate their patients. So this is patients from across the world, from France to Spain to Germany to the United States to Australia. And these are images showing lesions, ablation lesions. This is posterior wall, a lot of patients. And you want to see PVI. Everybody had the PVI plus, PVI plus. We never told them how to ablate, but every single patient gets a PVI plus something else. And you can tell the lack of lesions, especially on the right side. The left side is very well, and the right side not very good, but you can see consistent lesions across this board. And that's very important. So we looked at how many patients in DCAF1 have lesions like this across the veins. And we find that's only around 7%, 6.7% have all 4 veins have lesions like this. 3 veins, 8.5%. The majority of the patients have 0 or 1 vein encircled from DCAF2. This is a 330 patient study. And these all great operators have done thousands of patients. They tried to ablate the prominent veins, and the lesion formation is bad. This is a paper that Akum published in sub-analysis in DCAF1 in JCE. The only powerful predictor, and this comes back what Professor Arntz told you, is we looked at fibrosis in green and ablation in red. We called the red in Utah clean fibrosis, or clean lesions. We called the green dirty fibrosis. The images I showed you before, the biopsies, the histology. So the more this green area is covered with ablation lesions, the less of this, the less non-ablated, fibrotic area left behind, the better the outcome. It's a very powerful predictor for outcome in DCAF1. 1%, there's always 1% risk of recurrence. So, and this is a quartile, 4 quartiles on residual fibrosis, left behind areas. The higher chance of patient recurring. It's a very powerful predictor of outcome. So based on that, I mean, there's a lot of data. You've seen some of from Dr. Arntz as well, and Dr. Jadidi from Bordeaux. When he was in Bordeaux, now he's with him. But Dr. Wilbur in Chicago, looking at rotors or rotational activity, I'm not sure what you want to call it, whatever you want to call it, but it seems like to be anchoring around this fibrotic area. Isolated patchy fibrosis or border zones of fibrosis where he's seeing this to be anchoring. And this is a paper from Pierre Jaiz in Bordeaux where he's doing the surface ECGI mapping system to look at rotation activity. This is a paper actually in Press coming out soon. He's anchoring those around the fibrosis. It seems like the fibrosis is a place for everybody to come and settle with. We're looking at the voltage. Hopefully MRI can define it better. This is a paper from Dr. Yamaguchi. He gave a lecture in Utah last week looking at low voltage areas and ablating them to improve outcome. He defines fibrosis as 0.1 millivolts. He ablated those using ASI system. And this is a paper you heard about a whole lecture today from Dr. Jadidi, doing low voltage area. Again, they define it between 0.5 to 1 millivolt, as I said. My issue with this disease area, is this 0.5 millivolt? Or is it 1.7? Or is it 0.9 or 1.9? I don't know. And the same thing for here, 0.5, 0.7. If you put it at catheter here, you may get more, you may get plus. The reason I'm telling you, I think fibrosis, everybody knows, but unfortunately, the only way we look at it is from inside the heart today. MRI allows you 3D, and this is a new way of looking at it from the image processing perspective in Utah, where we're looking across the wall now. We're taking the MRI image I showed you. It's not only intensity, but we're looking across the wall. And this is a work from Alan Morris, and this is, for example, this patient, we have a grade of depth of fibrosis. Before we give you green and whitish and so on, this is now we revealing this, which is very important, not part of DCAF2, but it's very important because when I ablate everything, this is 2.2 millimeter of fibrosis red, and this is 1.1, 1.5. And I can't imagine if you put a catheter here to make this low voltage, this may give you 1.5 millivolts or 2 millivolts in an 11 millivolts appendage or 10 millivolts appendage or 9 millivolts appendage. So keep in mind, the MRI is looking at 3D fibrotic changes or fibromyopathy or fibrofatty implant changes or disease. While low voltage area is really looking at areas which are very disease and compact to give you this bipole of low voltage. So this is actually, in fact, that Dr. Siebmeyer, his name is down here, you're not seeing it, who joined us from Munich for a 2 years fellowship. This is one of his first. He looked at genetic changes and fibrosis. He worked with Dr. Wakili in Munich. And one of the projects you're looking at is came in and started voltage mapping the patients. And you can tell here, if this patient here, if you stick with 0.5 to 0.5 threshold of fibrosis, you see nothing. The moment you increase your scale, you start seeing changes, which matches the red area as the green, not exactly right. And this is study, you have a study now with 18 patients correlating. This is another patient. You see it here, the same thing. You have to change your threshold. The more you increase it, the better you get matching. So voltage is not 3D, which seems to find good results in some patients when they involve the atrium and anterior wall. But keep this in mind, please, going forward. This is another example from Dr. Siebmeyer as well, changing the thresholds higher and higher on the cardio system to match your fibrosis and MR. You always get there, but there's a way around it. And now this transmurality of imaging will help us a lot. And this brings me to this slide, which is how we are ablating AFib since DCAF1 came out in Utah. So we are isolating the fibrosis and debulking or homogenizing the fibrosis, just like Dr. Ans is doing in the voltage area. We are ablating everything. We don't isolate only because we don't take any chances. We're homogenizing the fibrosis. We're doing this now recently using the cryoballoon. This is using cartosound, very expensive procedure for us. We use cryo and carto. So we take the balloon as a shell, try to move it to match it on top of this fibrotic area. This is a multiple shell. Probably we freeze 100 seconds to 90 to 100 seconds, and we look at the lesion and MRI after, but we do probably 15, 20 freezing per vein, per atrium to finish. And this is a result in this patient, for example, in terms of lesion after cryofibrosis matching debulking. DCAF2, we took this idea, what we learned over the years from the guys in Freiburg and others, to look at 3D, what has happened if we ablate 3D fibrosis. There is 42 sites worldwide involved. Professor Arns is one of them. We have Dr. Atenza in Madrid, Dr. Montt, and hopefully Felipe and Barcelona will be part of the study. But these are the studies involved. I welcome anybody who would like to be part of the study. It's 980 patients. We hope to stop at the first analysis at 600 patients. If we see enough, we power the study very high to be only 10% difference. And randomized endpoint-driven, as I said. We're randomizing patients to PVI in persistent AFib versus fibrosis-guided, and everybody will be monitored with a smartphone device. So we have a lot of data in terms of avoiding patients coming to the clinics for visits, 12 months follow-up. PVI, you know what that means, everybody knows, and this is the fibrosis image. So we want to homogenize this fibrosis image per MRI, which is being integrated into CAR2 ESI and the Arritmia system. To conclude, and hopefully I will report to you the DCAF2 when you invite me back here in 3 years from now, the results of DCAF2. We're going to learn a lot about the fibrosis ablation guided per MRI, and we're going to learn a lot about the lesion formation right? Because multiple technology when used, we'll have tons of patients to look how the lesion forms 3 months after the procedure and the progression of lesions after the procedure. But this is the protocol we use in Utah. And full disclosure, we in Utah, although we are the PIs of the study, we are not ablating anybody in DCAF2 because we are biased. Because we are very biased, we're using this protocol already. If you have Utah 1 and Utah 2, we usually ablate them and look at fibrosis. In Utah 3, if the fibrosis is really large and patchy and widespread, we are very concerned how to approach it. And these patients are still trying to understand what to do with them. There's 3 studies we're doing in Utah, drugs versus reversible fibrosis, same thing with Utah 4. And very important to understand that the ventricle is part of the decision-making process. The same thing for classification for stroke prevention. We never, ever stop blood thinners in these patients. Independent from CHAD 1 or 2 or CHAD VASC, we just don't. We are worried to stop the blood thinners here. Here, obviously, we use the CHAD VASC score to guide us in stopping anticoagulation. Recurrence, this is very important. Every patient gets a repeat MR, obviously, and we see is this widespread localized area or widespread area of fibrosis after recurrence, and based on that, we decide our approach. And last but not least, I am honored, and Felipe was one of these guys as well, the Karma Center. We are now 56 people working on this concept, how we track fibrosis, image fibrosis, arrhythmia, and sudden cardiac death. I invite you to join this website. Any questions you have for us to integrate and collaborate, we'll open to. Thank you for inviting me and listening.